This is On Air with EUFOREA.
So, welcome. We are here at the EUFOREUM, a symposium organized by EUFOREA on respiratory care and type 2 driven diseases from childhood to adulthood. My name is Susanne Lau from University Medical School, Charité in Berlin. I'm a pediatrician, and it's my pleasure to introduce Eckard Hamelmann, director of the Children's Hospital and belonging to the university in Bielefeld. And as pediatricians interested in type 2 driven disease in childhood and adolescence, we would like to discuss a little bit the concept of remission. While in previous times we were more likely to speak about disease control, which should be achieved for the patients, we are now thinking of the concept of remission, which is a bit tricky, I think, because we still have different ideas about what remission really means. Does it mean long-term control, more than 12 months with therapy, or is the real remission more the stop of the disease also without a therapy? So, Eckard, what do you think? Why the concept of remission may be important also for children?
Yeah, first of all, thank you, Susanne, for inviting me. It's a great pleasure to being here. And I enjoy talking about this type 2 inflammation and diseases in early lifehood, in pediatric allergy. Remission is a big word for us as pediatricians. We always believed in remission as being a natural development of undisease. So becoming again healthy and having had a disease. So it's a word that has a long history and is very valuable for us. And so it's not very surprisingly that this new word remission in asthma therapy was driven by adult pneumology. But we have to rethink it. I mean, the problem, as you said, is that the control term that we used for the last, I would say, 2 decades, and we taught a lot about this control to our students, to the researchers, to the GPs, that this is the golden calf, so to say, that we have to look for. Now we say it's remission on treatment, and I think there might be this compromise that we have a natural remission, which is still what we believe in the pediatric field is losing a disease, and that we have remission on treatment. And maybe then the concept is not bad. I would rather prefer the term sustained or long-term control, because then we don't need to throw control as a term overboard. We could use still control, but basically it's the same. Remission is long-term control, meaning you have no systemic corticosteroids, you have good control of lung function, you have good symptom control, you have no exacerbations, and that is for 12 months. And that is the difference to the usual word control, where we only look for a shorter period of time. So maybe we are flexible and we use the term in future.
Yeah. Do you think that the use of the term has an implementation on adherence of therapy? So if you sort of convince the patient that remission is so important, that is the complete control with improved lung function without oral corticosteroids, like you said, because we assume that the remission and the decrease of chronic inflammation may have a disease modification, at least, and we hope that in children this could be the case.
I think I'm afraid that I can't share your optimism, to be honest. I believe that this wording of if it's remission or sustained control will not change the beliefs or the adherence of the patients. I mean, they still use their medicine, they don't use the medicine, and we always see it. We see it every day. They're not following us completely. We have some therapy plans, or treatment plans, but they don't use it as we say. And if we now use the word remission, it doesn't change the world of the patients, but it can change how we talk with the payers. It might change how we talk to our GPs and the pneumology and the pediatric guys outside, that we say you don't have to look only for the actual control, but look to the future. We look for the future risks, exacerbation, steroid use, and rather have in mind that this disease is a chronic disease and that you have to treat it in a chronic way and look for real absence of problems over a longer time period.
Yes, and maybe it could also implement that the therapeutic agents, which are now in the last step of our therapeutic scheme, of our step-up approach, could be introduced earlier. I think it's much easier if you have a specific response to the suppression of IL-5 or IL-4 or IgE. If you can block this specifically within monoclonal antibody, for example, the remission is easier to be achieved compared to really high doses of inhaled corticosteroids, which have more side effects, of course.
Absolutely, Susanne. I think this is the reason why I want to give up any resistance to the word remission on therapy, because I think the long goal is that we will be able to treat our patients earlier with the antitype specific or more anti-inflammatory drugs and not only with the steroids. So this would be the good part of using the term remission, that we have biologics now available even for children up from the beginning of 6 years for asthma, that we can use the biologics in terms of using biomarkers and then choosing the right biologic, and that we do not have first to treat a patient with long-term and high doses of inhaled or even systemic steroids before using the biologic. That would be a long-term goal.
Yeah, that's a good final sentence. So thank you very much.
Thank you very much.
This was brought to you by EUFOREA, inspiring the future of respiratory care. This podcast was supported by an unrestricted educational grant from Sanofi Regeneron.